Hello, I'm Dr. Camille Collett. I'm here to talk about advanced care planning and how to fill out a POLST form, Provider Order of Life-Sustaining Treatment, with patients who have serious illnesses. The learning objectives are to know the difference between an advance directive and a POLST form, knowing the benefits of a patient having a POLST, as well as the key components of how to properly fill the POLST form out. There are many resources available on advanced care planning and how to fill out the Provider Order of Life-Sustaining Treatment, and we will be reviewing that. The purpose of the POLST form is to really improve patient care by personalizing it and making sure you understand the patient's values, their goals, and preferences for medical care. An advance directive is a different form that actually designates a decision maker for the patient when they are unable to speak. That decision maker is supposed to follow the patient's wishes, and if the patient is competent to sign a POLST form, they can. Otherwise, you do this with the decision maker. The POLST form, as we mentioned, is a provider order of life-sustaining treatment. It is an actual medical order signed by the medical provider with the patient or their decision maker. This form helps to document the patient's preference as to what life-sustaining treatments they would want, such as CPR. These medical orders can be followed by emergency medical services, hospitals, and care facilities. There are many benefits to having an advance directive as well as a POLST, but it's important to understand that this allows a patient to express their wishes as to what they want at the end of their life. It really can reduce the emotional burden surrounding these conversations if you have had this before the patient is in a serious medical situation. The importance of the POLST is to also review the medical conditions the patient has, as well as their goals of the medical care. This POLST is a voluntary form, and if a patient does not want to complete it, it is not forced upon them. Plus, it can be reversed at any time the patient desires to have a change in this medical order. Advanced care planning, also known as ACP, is important because it can document their medical wishes. They need to be regularly updated, and then we also need to respect them. There are many people who have never completed an advanced directive, also known as a living will. If there is no designated decision maker on a legal document, there is an order of who we talk to as medical providers. First the spouse, then the adult child, a parent or adult sibling, and even an adult grandchild or grandparent. This order of decision makers has been established by a statute with the Utah State Legislature. The Utah Advance Directive is available on the website utahaging.org. It has the 4-page form that you can fill out, and this can be helpful when completing a POLST. Now we're going to go over the completion of the POLST form. It has many areas to fill in, including the patient's last name, first name, and the date that you're filling out this form. You have to include the patient's date of birth, and if you have, the last 4 digits of the Social Security number. If you don't, you can leave this portion blank. It should include their current address and who is the medical provider that is in charge of their care and their phone number. The important thing of describing the medical diagnoses is very important so that the patient's serious illnesses can be documented. But the next section, where it says patient stated goals for medical care, is really more about what gives them joy in life. What makes life worth living? Why would they want to have a medical intervention? Is there something that will improve their life so they can have a better quality of life? you need to actually have a in-depth conversation with these patients to find out what matters to them. If they are no longer able to speak for themselves, you need to talk to the decision maker for the patient. The next section is Section A. This helps to outline if a patient wants CPR or they don't. The important thing to understand is what is CPR and when would they need it. The pulse form in Section A is very specific. It says if the patient does not have a pulse and they are not breathing, check one of these. They can say, I want to have CPR, and then they check the first box. If they do not want any attempt to do CPR, they will have the DNR, which is the do not resuscitate, also known as allow a natural death. Some patients are just not sure, and they want to be able to say, I don't know. The third box is for that. If you choose not to make a decision, the default is that someone will attempt CPR. Section B is with the medical interventions. If you choose full treatment, meaning you want any and everything done, then you need to check the first box in A that says attempt CPR. However, if you do not want CPR, if your pulse is not there and if you are not breathing, then the next box, limited medical interventions, can be appropriate. This is for antibiotics, IV fluids, if you have a surgery need. Limited additional interventions can be done, and yet the patient can be designated as do not resuscitate in case their heart stops and they are not breathing. The third box of comfort measures is more when the patient really does not want to go back to the hospital. They want to be kept comfortable at home, if at all possible. This does include pain medications, food, anything that the patient wants at the end of their life. They can have hospice involved, or if they want to just have family members and not have hospice, there is a very good way to help people with their pain and suffering to avoid that. However, if this cannot be done at home, patients who are on comfort care are allowed to go to the hospital to get medications to help alleviate their pain. If you decide not to make a decision in this Section B and choose D that says, I don't know, then the default is everything will be done. Many people have heard about CPR, and in people 65 and older, if they are hospitalized, the outcome of CPR is not as rosy as we think. If 100 people are in the hospital who've had a cardiac arrest, 49 will die during the actual resuscitation. 34 will die before they are discharged. 7 will die after discharge within 1 year. 10 are alive after discharge, but have complications that can make their life more challenging. The next section of the pulse form includes whether the patient wants artificial nutrition or feeding tubes. You have the option, if you choose, they can have long-term feeding tube. Many people have survived for many years with feeding tubes, and that may be something they are willing to live with. If you choose not to make a preference on a feeding tube, the default is that you will get a feeding tube. The next section is if there is an advance directive that you've reviewed with the patient or their decision maker. If you have the advance directive, you can check this box. If you don't, then check that there was no advance directive available. You need to designate who is their decision maker in the health care agent box and their phone number so they can be contacted in case of emergency. If the patient is willing to say that they don't want this changed, they want this followed specifically, they can mark the box, I, the patient, want this order followed strictly. But if they want their decision maker to have some leeway, the first box can be marked. If there is more to discuss, you can put it in the discussion as to who all was present during this conversation. The required signature page is very important to be filled out properly, including the name of the patient. And if they are the ones signing, then you need to put that in there. If the person signing is the decision maker, their name goes in this box. If they are the husband or wife, you document that, and then they sign. Medical professionals will sign in the lower boxes. If it is a pediatric patient, then 2 medical professionals need to sign this document. They need to include their name and their license number and the date that they signed. And when it is completed, you need to make a copy and print it out. This is a hard copy that is then taken to the hospitals and can be uploaded in the medical system. There are many, many options of uploading depending on what medical system you're involved with. There are additional considerations to be made when filling out the POLST form. In situations when there's a pandemic and family members cannot be present to physically sign the form, the state of Utah has allowed 2 witnesses in the medical profession to hear the consent and then write this on the form to complete the POLST legally. There are many forms from other states that have been completed, and they may only have that form. Emergency medical people will honor a POLST from another state. There is also a national form that has been developed by polst.org and is available and can be used, and medical professionals will recognize that as a legal document. As technology improves, these forms can be available electronically. Having conversations about end of life can be very challenging. Caregivers are overwhelmed and many times want to avoid the topic. There are many, many tools available on the internet to help with having these conversations. The treatments that are available can be painful and not always understood by family members or the patient. Cultural differences can make these conversations very challenging and need to be handled with sensitivity and respect. Medical providers can be hesitant to have these conversations, but there is training to help us learn how to talk about these difficult issues. There are many resources to help people have these conversations, and they can be found at utahaging.org.